So sorry, my camera's not working on my computer today, so just my voice. But I'm Erin Montgomery, and thank you everybody for joining us today for our echo session. We're going to be talking about respiratory illness in pediatric patients. So I think most of you guys know me, but I'm the coordinator for our outreach program. We've come and done SIM, I think, with most of you guys. And then since June, we've been holding these monthly echo sessions and just a time for all of us to chat about pediatrics. So we'll go a little bit over the program. Kamal, do you want to introduce yourself?
Yeah, hey guys, I'm Kamal. I'm one of the ICU attending and work closely with Erin with the PCOM team. I've seen and been to a lot of these sites, and we're very excited to have this ECHO platform and another way of engagement with you guys and work with you to improve the quality of pediatric care and work with our partners in the community as usual. So thank you for your time.
And then I'll go ahead and let Zach introduce himself. He's going to be talking for us today, so we'll give him a minute. But Zach, if you want to introduce yourself.
Yep. I'm Zach Behrens. I'm probably have met some of you. I've been working with the PCOM team for a little over 2 years now. I'm happy to have the opportunity to talk to you guys a little bit about respiratory distress and failure today.
Hey, Catherine. All right, and then we've got a couple people on, so if you guys want to just go through and introduce yourselves. Let's see, we've got Michelle. Michelle, you there? You're muted. Okay. Someone else. It looks like Allison's on. Are you here with us, Allison?
Yes. Good morning. I'm Allison Wilson, the unit-based educator at Community Hospital Anderson in the ED.
Great. Thanks.
Thank you.
Then Dawn.
Hi, I'm Dawn Solon-Wright. I'm the clinical nurse specialist for Community Health Network's emergency departments.
Okay. Well, I think it looks like we have someone on the phone. I'm not sure who that is.
Yes, my name is Brenda. I work at Ball Memorial Hospital in the emergency department.
Oh, great.
Yep, just joining. Just got an email about it, so I thought I'd hop on in.
Well, welcome. Thanks for joining.
Thank you. Yeah.
And then I think we've got Kristen.
This is Christy Crotty. I'm the unit-based educator at Community East in the emergency department.
Thanks for joining. And then.
Hi, this is Michelle Ruzzi from Hendricks. Somehow I hit the wrong button, but I'm back.
Thank you. Thanks for joining.
Yes, thank you.
All right. We'll go ahead and get started. So if this is your first time joining, just kind of give you an idea of what the program is and what we're doing. But our goal is to provide pediatric education and to also kind of create this community of providers and caregivers to share knowledge and experience. So everything about these sessions are an educational environment for learning and collaboration and hopefully kind of working together to help improve pediatric care. Let's see. Okay. So for educational and quality improvement initiatives, we are recording this session. We record all of our sessions. So by participating, you're consenting to be recorded. If you guys have any questions, just let me know. And the recording is just shared with other caregivers and providers. So that if they couldn't actually attend, then they can still watch it. For attending, you also get CME and CEU, and so there's 2 slides kind of explaining how to do it. You just have to set up an account with the School of Medicine CME office, and then and certainly I can send this to you guys if you need it. but then here's the event, the claim code for you to be able to claim your CME or CEU. You will get 1 hour, and you have to claim it by 11:59 tonight. And here's our disclosure summary. And then let me switch out of this and pull up Zach's. So today is going to be our first of 3 sessions talking about respiratory, which I'm not sure if you guys have experienced any pediatric respiratory patients yet. I would imagine so. So today we're really going to focus on respiratory distress and failure, signs and symptoms, that kind of stuff. And so Zach's going to go ahead and get started.
All right, thank you. Like Erin said, this is kind of the first of 3, so let her get the slides pulled up.
Can you see them?
No.
Okay, stand by. How about now?
Now I can, yep.
Okay.
So today is primarily going to focus on some epidemiology, kind of what these kids look like when they come in, the types of history that you get. Break it down into a little bit of different etiologies. I'm not going to cover all the different things that can cause respiratory distress and failure. I'll show you kind of a bigger list just to give you an idea, but it's lots of things. But I'll try to hit on some common causes that I know are starting to come through the ED, and then some other things that I think can cause respiratory distress that aren't actually pulmonary in nature, that are also scary and need to be recognized. And then again, this is the first of 3, so I'm not going to try to not drift into the treatment and kind of some of the diagnostic things that can be done as well, because those will be covered at the next session. You can go ahead and go forward. So we'll start just a little bit with just some epidemiology. I'm actually trained in epidemiology, so I find it to be very interesting. You can go ahead forward. So, you know, as I mentioned, there's a lot of different things that can cause a child to have respiratory distress or failure, but by far the most common is viral URIs. And it's weighted so heavily towards viral URIs. There's actually a lot of seasonal variation in when kids come in and present with the chief complaint of respiratory distress. And it typically peaks kind of starting around now and going all the way through the end of winter. And also as a result of that, you get a lot of different age distribution and what types of, or what age patients present with respiratory distress or failure. You can go ahead forward. So this slide is from an article that was in Pediatrics. It's just looking at pediatric patients that were on one of the government insurance plans. And the left-hand column is urgent care visits. The right is ED visits. And you can see kind of in parentheses is the percent of patients presenting with these chief complaints. And this is based off diagnostic coding criteria, so it's not completely exact, but you can see upper respiratory infection just dominates. You could imagine that fever probably has a lot of kids that have respiratory symptoms in it. Other respiratory infections like pneumonia appears in both lists, and then asthma appears in both lists as well. So, you know, in terms of numbers, you just see a lot of kids that come in with respiratory pathology. You can go forward. And I mentioned there's big seasonal variation. So this slide is from the AHRQ, which also looks at, you know, coding, how kids are coded in terms of diagnosis. But the purple lines on this graph are children that present with respiratory conditions. The blue is actually injuries. So you can see there's kind of a discrete or distinct seasonality for both, but the purple spike, again, starting kind of right around now in the kind of October through December, and start to go back down kind of starting in April. So it's about half the year where you really see these spikes in respiratory presentations. You can go forward. And this slide's from the same group. It kind of breaks it down by age group. And these are almost all infectious etiologies with the exception of asthma. but I think the purpose of this slide is, as you can see, there's definitely a younger preference in ED presentations with respiratory distress. And again, in all age groups, though, URIs are the most common presenting diagnoses. You can go forward. So just a little bit about what these kids look like when they come in. Go ahead, forward. You know, I think when you're taking a history, you know, sometimes you get very clear respiratory symptoms. They're breathing fast. Parents, you know, say they can hear wheezing. Stridor tends to be a fairly obvious one. You know, sometimes they say you can hear rattling in their chest. You know, cough and rhinorrhea are obvious ones, but there can also be more subtle symptoms that they complain about, even if they're not having those pulmonary symptoms: poor feeding, agitation and fussiness. In an older kid that's maybe in school, you might get, you know, they're not participating as much in gym class or on recess as they used to. And in fever is kind of this very non-specific thing, but often comes along with a lot of these presenting problems. Go ahead, forward. And then, you know, I've kind of broken down this talk when we get into specific etiologies, and I'll talk about exam. And when I'm talking about exam, I'm talking about things that you can kind of see from the foot of the bed. I'll talk about auscultation in the next slide as well. And I kind of broke that out as a specific part of the exam. But kind of from the foot of the bed, you know, these kids, they often look tachypnic. There's a lot of accessory muscle use, so retractions and head bobbing, belly breathing. You can get nasal flaring in younger kids, and you can get grunting as well. There can be variations in this between whether the kid's calm, whether they're agitated. You know, these things can change as you do treatment. So it's good to get a good baseline as far as what they look like, because they're kind of guide where you think, you know, what might be happening with the patient, and then how they respond to your treatments. Go ahead, forward. Thinking about auscultation specifically, I think it's important. You know, it's provider as far as, but I think there are certain things that you can get consistency and quality, particularly. You know, I might hear a wheeze and you might hear a rhonchi or a crackle. But we probably should be in agreement as far as, are they in both lungs and all lung fields? Is it with every breath? Is it only with certain breaths? And those things can be really important to figuring out, you know, is this asthma or is it bronchiolitis, and trying to differentiate as far as what it can be. Mitigating factors, again, I think can be really, really important. Does it get worse when the kid's screaming and almost go completely away when the kid's completely fine? Does it change with positioning? Things like that can help point you down to the correct diagnosis. So auscultation is certainly a very important part of the exam. You can go forward. And then the other thing, and I don't talk a lot about vital signs in here other than respiratory rate, but hypoxemia is kind of the other one. We typically think of a number of reasons that a patient can be hypoxemic, but there's in practicality, there's two that we really see a whole lot, and then maybe one or two that we see a little bit less frequently, and a couple that we see hardly at all. You know, decreased inspired oxygen we just don't see here. We don't live at altitude. It would be really unusual to think of a reason why somebody would have that. Shunt physiology we certainly do encounter. You know, if the patient has a history of a cardiac defect, VSD that's unrepaired, if it's a Down syndrome kid that has an unrepaired AV canal, somebody with a known AVM that's unrepaired can have shunt physiology. The two that I have bolded here, VQ mismatch and diffusion, are probably the most common ones that we see. And VQ mismatch, I mean, really we see it with atelectasis is probably the most common reason. In your adult patients, you may think more of like a PE causing VQ mismatch from changing the perfusion, but that's a pretty rare cause of hypoxemia in kids, and it's almost always when we see it, it's due to atelectasis. Diffusion defect is kind of, it's a theoretical one, but I think it's one that we all accept. But you tend to think about that in something where there's like fluid in the lungs, pneumonia, pulmonary edema, or something inherent to the architecture of the lungs. So some of the rare interstitial lung diseases that kids get that might cause a difference in the distance between the air in the alveoli and the blood in the capillary, and how much space has to go for that oxygen to diffuse. I think everybody worries about hypoventilation, and I certainly do as well. But you have to be pretty profoundly hypoventilated in order to have hypoxemia. So you don't really get hypoxemic unless you've got kind of multifactorial hypoxemia. So from just hypoventilation alone, a CO2 in the 50s, 60s, even 70s, and maybe a low 80s is probably not going to cause a desaturation. It really is caused with the CO2 that's in the upper 80s, low 90s before you're going to start seeing desaturation strictly from hypoventilation. And in a low mixed venous oxygen, you usually don't see this in isolation. It usually typically occurs in combination with one of these other things, unless it's a baby with a heart defect. But that's just where the demand in the body for oxygen is so high, like due to sepsis, for example, that the oxygen extraction from the blood is really high. So when the blood returns to the heart, it has a very low saturation. And then if you've got something like a pneumonia and you're going to have poor diffusion, you have an additive effect. Oximetry is a very important thing. I'm going to talk about it like in relation to some of the specific etiologies that I talked about and what I would expect the oxygen saturation to be, because I think that can kind of help guide what you think about with treatment, which of course we'll talk about next week. Go ahead, forward, Aaron. So we'll talk about some specific etiologies now. You can go forward. I've kind of broken these down, first of all, on UpToDate, this is like the next few slides are just a list of all the things that UpToDate lists. I have found similar lists on Pediatric Review articles and other pediatric articles. You can go forward. But it's a long, and forward again. It's a long, long list. I'm not going to talk about all of them. I tried to, again, pick ones that are common or ones that are maybe representative of a process overall. So like neurologic depression, for example. So I'm not going to hit all these. One thing I'm not going to talk about is chronic respiratory failure. I'm sure some of you have trach and vent patients in your population that come into your ED. You may know very well who they are because they're oftentimes frequent flyers. I would just say they can get all of these things. They can get bronchiolitis, they can get pneumonia, they can have some of the other things that I'm going to talk about as well. The other thing I'm not going to talk about is trauma. Trauma can certainly lead to respiratory depression, but I think that's kind of a conversation in and of itself. But we'll kind of hit these common pulmonary etiologies, and then I have a few kind of non-pulmonary etiologies as well that I think are important to think about. So you can go ahead forward. So I have it as bronchiolitis. I think we tend to kind of lump bronchiolitis and URIs all into one basket in terms of how we approach them diagnostically and treatment. So bronchiolitis really is a specific thing. It's an inflammation of the bronchioles. It's different, I would say, than asthma, because asthma also has kind of these small airway inflammation as well, and mucus production, which bronchiolitis certainly has. It doesn't really have that hyperreactivity that asthma has. And then obviously it's caused by an infectious cause. And I would say asthmatics, one other difference is they tend to have kind of this persistent inflammation of their small airways, which is why they're often on controlling medications, whereas bronchiolitis is definitely a very discrete thing. They don't need typically any sort of controlling medication. As I mentioned, there's a definite age preference with this. So these are typically toddlers, infant through toddlers, but in any age you can have a URI. And there's certainly seasonality to it with kind of that October through March pattern, which kind of caused those big spikes that we saw on that graph a few slides ago. These kids come in, they have very kind of typical respiratory complaint histories. The parents will talk about fast breathing, they'll talk about runny nose, they'll talk about cough. Some of these kids have fevers, but it's not 100% of them. feeding can be a chief complaint as well. A lot of times it's poor feeding due to rate of breathing or work of breathing rather than just poor feeding in general. When you examine them, I mean, again, you can have a lot of variation. Tachypnea, retractions, accessory muscle use are certainly things that we worry about. And when you listen to them, I think this is the one where like I could listen to the patient and then have Kamal listen to the patient 5 minutes later, and we could get 2 different exams, and it's because the patient actually has 2 different exams. They cough in between, so they were wheezy when I listened to them. They cough, they move some mucus around, and then Kamal listens to them 5 minutes later, and he doesn't hear it at all. And same with kind of the physical exam. They may cough and they may clear some mucus, and there's retractions that look horrible when I saw them, don't look as bad when he goes in. So these kids, I think, really they vary. They're kids that you kind of have to think about on an inpatient setting. I think about them very like 12 to 24 hours at a time as far as how they're doing, because their exam changes so frequently. That's harder to do in the ED, right? Because you just don't have them, hopefully not there for 12 or 24 hours. The other thing with these kids is hypoxemia is not, if you think about, again, the causes of hypoxemia, they might have it, they might not. I would say the most typical reason that they have it is because they have some atelectasis and they have some VQ mismatching. But a lot of times these kids may look crummy and have okay SATs. Sometimes they look very happy and look crummy, and that can be okay as well. But you're going to start seeing them, if you aren't already seeing them, they're going to start coming out of the woodwork here very, very shortly. I think you can go forward. Now, pneumonia is a little bit different, so it's definitely an infection of the lung parenchyma itself, and there's no real age or seasonality to it, other than that I would say that it frequently comes as a secondary infection to viral infections. So October through March is viral respiratory season, it's influenza season. We've actually seen our first influenza case here already. And pneumonias can come secondary to those viral infections. So, but it's not necessarily something that I think about like, oh, there's a pneumonia season per se. With that being said, viral prodrome is a very common thing to hear on history. These kids often have fevers, like true fevers. It's not just the fever to touch or low-grade fever, kind of just general malaise. A lot of positive constitutional symptoms on review of systems. And then they can have localized chest pain, especially if it's a lower lobe pneumonia that sits on the diaphragm. An older kid, can definitely say like, I have pain right here and point to it. And then you get you listen, you don't hear breath sounds there, you hear crackles there, you get an x-ray, and there's a big consolidation right in that spot. These kids, again, they can have a pretty varying exam, but I tend to think of kids that have pneumonias, they look pretty sick. They just don't look like they're feeling well. It's typically due to the fever, but they may or may not have increased work of breathing. If they're having pain, they may have splinting, but they just kind of don't look well. And on auscultation, and pneumonia really is a clinical exam. You don't need to have a clinical diagnosis. You don't need to have an x-ray to diagnose it. Typically, you're going to have vocal findings. Crackles is kind of the classic oscillatory finding that you get. And hypoxemia is almost in 100% of these kids. And it's one of the ways for me that if I have somebody that I'm like, is this bronchiolitis with atelectasis or pneumonia, or bronchiolitis with a secondary pneumonia? If they don't have hypoxemia, I'm often not as worried that it's a pneumonia. It's typically probably just atelectasis on the x-ray and bronchiolitis. So to me, higher fever, hypoxemia, and focal findings, I'm going to treat it as a pneumonia. Diffuse findings, maybe some smuts on the x-ray, but SATs that are okay, I'm probably not going to treat it as pneumonia. You can go ahead, Ford. Asthma, I've kind of already talked about this a little bit, but it's kind of this multifactorial process that leads to airway inflammation. You get hyperreactivity, you get increased mucus production. And these kids really do walk around with some baseline airway inflammation, all the time. Is there an age preference? You know, it can certainly be in all ages. I think historically we didn't like to give the diagnosis of asthma to kids who were like under the toddler age. I certainly have some reservations about it because then they get this label and then they've got an inhaler their whole life. And it really can impact them for a long time, kind of having this label of asthma. With that being said, there's kind of this new movement to have this diagnosis of what's called toddler's asthma, which is in this kind of kids that are under the age of 3 that seem to have asthma, that respond to asthma treatments, but you aren't quite sure if they're going to, you know, continue to be quote unquote asthma when they're 5 or 6 or 7 years old. So I think that's something that we're starting to talk about a lot at the pediatric centers, and I think will probably become more commonplace outside of kind of the big academic centers as well, because it does help give a diagnosis to say a 3-year-old that wheezes and responds to asthma, often with viral infections, but it's not going to wheeze when they're, say, 5 years old. Seasonality, I think there is seasonality. I think within individuals, there's definitely seasonality. You know, people who are asthmatic typically, you know, especially if it's like an older teenager, they can tell you like it is worse during the first cold spell of the year. Like I always have to go to the urgent care the first, you know, frost of the year, or it's worse with spring allergies. At the population level, I think, you know, there's a baseline level of asthma that we see kind of all year long. There certainly seems to be spikes probably more around seasonal allergy times, depending on where you live in the country and how big of a pollen and allergen burden that you have. You know, as far as history, if it's a new person, you know, things that point me down more towards asthma as opposed to bronchiolitis or some other viral infection that might be causing wheezing, particularly in a younger kid. You know, if they have a family history, if they have allergies, if you look at them and you're like, oh my gosh, there's all this eczema all over the patient. And then obviously if they have any past response. And then, you know, I always want to know triggers because these kids are often triggered by people who smoke in the house, and there's always a good opportunity to talk about how you can reduce those triggers. From an exam standpoint, you know, again, looking at them at the foot of their bed, you can see accessory muscle use, and then these kids tend to have a very like forced or prolonged expiratory phase. And really anybody with kind of obstructive physiology tends to have that. When you auscultate them, I mean, they can be pretty scary at times. I mean, you can put a stethoscope on and hear almost nothing, which is quite frightening. Again, you're going to hear that prolonged expiratory phase and kind of forced expiratory phase. If they do have wheezing, it tends to be diffuse. It tends to be polyphonic as well, as opposed to one of the other things I'm going to talk about in a couple slides, which has more of a monophonic presentation. And then hypoxemia, again, I put maybe. I don't tend to think of asthmatics as having low oxygen saturations. With that being said, it's very common, it's going to get a little bit into treatment, when you give them albuterol, that they'll have a little bit of EQ mismatch initially as the areas of the lung get ventilated differently and blood flow adjusts accordingly. So sometimes their sats do drop initially with that. And I think a lot of asthmatics, you know, they come in, they get those 3 albuterol treatments, and their sats go down as we would predict because of the VQ mismatching that's going to occur, and then they get stuck on oxygen, which maybe they need there in the short run, but a lot of times it can come off pretty quickly. You can go forward, Aaron. Croup is one that we'll see, and I think there's definite age preference, kind of 6 months to 3 years. There's definite seasonality. Maybe we're a little bit early in the year, but certainly as we get closer to winter, we'll start to see it more. It's usually, you know, it is due to a swelling of the larger airways. You know, parents come in, you know, Croup's interesting because you can have symptoms at rest, or you can have symptoms just with agitation. But, you know, the history that you typically get is that kind of seal-like cough is kind of the classic. Stridor, hoarse voice is one that you can get. Maybe with, you say, you know, maybe they'll just say their voice sounds funny. This is caused by a virus typically, so you may get fever, but you may not. And then sometimes, you know, parents come in with hoarse voice, but it you know, got better when they went outside in the cold air in the winter. That typically also points me down that there's some sort of swelling of the larger airways. These kids can look totally fine when they come in if they're a kid that's not going to have any symptoms at rest and they're comfortable. What I typically find is when I go to examine them, they typically have, because of their age, they typically don't like me examining them, and then they get worked up, and then their symptoms come out and show themselves, and they start to have stridor, increased work of breathing. Certainly more concerning if they're having them at rest. These kids really should have normal lung sounds. And, you can get stridor, if you oscillate with the stethoscope actually up over the trachea, you can hear it. A lot of times you can hear it without even a stethoscope. And then again, these patients really should not have hypoxemia. So, you can go forward. And then foreign body is one that we'll see. So it can be fixed or mobile. It's typically in the large or medium airways. It can occur in all ages. Typically, we think about it in under 5, but certainly if you have, for example, like an autistic kid that's 10 or 12, I've seen them have foreign bodies. Really, any age can have them, but typically we think about it less than 5. No real seasonality to it. Sometimes I'll say, foreign bodies I tend to think of them as either choking, so they come in like with the obvious, very acute. They were eating a hot dog that wasn't cut up small enough, and everybody saw it happen, and everybody, the kid got the Heimlich, and they're coming in for kind of observation and reassurance. Or a lot of times, but if they come into the hospital and get admitted, they kind of just get admitted with this diagnosis of respiratory distress, and we actually don't figure out it's a foreign body until maybe days down the road, because it's not causing distress to the point where you're going to do anything crazy as far as diagnostics. A lot of times the X-ray doesn't show asymmetry, although it can. A lot of times you don't hear monophonic wheezing, although you can. A lot of times you don't hear any asymmetry. But kind of the classic things that you'll hear, if you're going to hear them, are a monophonic wheeze. So the wheeze is the same with every breath. And typically it's very kind of focal, or at least localized to one side of the lung. And they may have hypoxemia. It kind of depends on how big it is, whether it's causing, any VQ mismatch, particularly due to atelectasis. The other thing, sometimes these kids have these foreign bodies for a long, long time. So sometimes the initial presentation of a foreign body aspiration is actually a pneumonia. And then you get the X-ray and you see asymmetry, and then you start to wonder, like, hey, could this actually be a foreign body that caused it? Which we certainly see that as well. We go forward. So those, as I said, I thought were kind of some of the common pulmonary reasons that we see respiratory distress, and I try to again hit some common things plus some things that affect different areas of the respiratory tree. So larger airways, smaller airways, the lung parenchyma itself, things that come with bronchospasm, things that don't. Just to kind of give you again just an overall picture of how pathology at different levels of the pulmonary tree can lead to different exam findings and different etiologies. I think there are other things, though, that aren't necessarily specifically pulmonary that we do need to think about. Some of them are really obvious, and some of them aren't. So you can go ahead and go forward. Anaphylaxis tends to be one of the fairly obvious ones, but certainly the respiratory, in addition to the cardiovascular effects of anaphylaxis, are the things that really scare us, and other things that can cause a kid a lot of harm. But it's, a hypersensitivity reaction, and it can occur in all ages. There's no real seasonality to it. Some of these kids come in with an obvious known exposure. They have a nut allergy. They were at a birthday party. The person hosting the birthday party didn't know that they had a nut allergy, and they served cookies with peanuts in them. The kid ate one. A lot of times, though, it's a new exposure, and we just don't know it, and we kind of have to work it up. I think the big thing with anaphylaxis, if you've got a kid that's wheezing that doesn't have an asthma history, and it seemed to kind of sudden onset, you're kind of thinking maybe this isn't asthma. Anaphylaxis really should have other systems involved. So that's one of the important reasons to do a good review of systems and to do a full physical exam is to kind of pick up on those things. So you're going to either get lip swelling or tongue swelling. You're going to get hives. nausea, vomiting, diarrhea, those types of things in combination with some wheezing or some difficulty breathing, and I'm certainly thinking about anaphylaxis. These kids can look kind of like anything. It can be, they can be talking to you very comfortably, but complain maybe of some chest tightness, and that might be all they show you, or they can be really in extremis. And oscillatory or lung exam findings or respiratory findings that they can have can be pretty widely too. They can have stridor, they can have wheezing, they can have hardly any air movement because they have profound bronchospasm. But again, remember, if it's a kid that you don't know about a new exposure, and you're certainly going to see those, there probably are other systemic findings on your exam that you're going to have as well. And again, they may or may not have hypoxemia, kind of depending on how profound their symptoms are and if they're having any atelectasis from it. Go forward. Heart failure, I think, is certainly one that we all worry about. And we do see it. Certainly there are kids that come in with known cardiac defects, and it can be fairly obvious, but sometimes it's not. We had a kid from one of the community hospitals about 3 weeks ago that came in with viral myocarditis that had tachypnea and some crackles on exam. That was very sudden onset, but was definitely due to heart failure. But heart failure is a very kind of complex pathophysiology that I'm not going to completely get into, but it's generally due to fluid overload and pulmonary edema contribute partially to or entirely to the respiratory findings. And I think it's important to think about that just because when you do think about treatment, it's very reflexive to give fluids to people that look like they're sick. It's just the thing that we oftentimes do. And this is kind of the one patient population that you can actually hurt by doing that. It can certainly occur in all ages. There's no seasonality to it. In babies are who I tend to think about it in, because these tend to be like either undiagnosed cardiac defects or like a known cardiac defect that's just progressed into heart failure, like unrepaired VSD, for example. A lot of times they come in with poor feeding, they come in with fussiness. If they're part of your health system and they see primary care and you can look at a growth chart, sometimes you'll see a very flat weight gain. A lot of times it's just tachypnea. And in their exam, they might look like failure to thrive. They might have respiratory distress. They may not. Sometimes they can just kind of be comfortably tachypnic because a lot of times it's just kind of a chronic process. Sometimes it's very acute, like the myocarditis girl that I mentioned, and then it can be very, they look very distressed. In babies, though, I would say that kind of, somebody that has a VSD that's progressed, it's often a more chronic thing. So they can kind of be that kind of comfortable tachypnic or comfortable retraction. It's just because they've kind of gotten used to the state that they're in. Auscultation, again, tends to be diffuse, and then hypoxemia tends to be common. This one's really hard, I think, to kind of elucidate whether it's heart failure or not. Again, you get the history of an unrepaired VSD, okay, you might start thinking about heart failure, but a lot of times you don't have that history. If the kid doesn't look completely toxic, but kind of looks, is hypoxemic, is working harder than you'd expect. I mean, maybe they have a low-grade fever. How do you differentiate this between bronchiolitis and heart failure? It's really, 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 really hard. And we have kids get admitted to both our cardiac unit and to our PICU that kind of get one diagnosis that eventually get moved to the other place because we change the diagnosis halfway through and we say, you know what, this really isn't bronchiolitis, it's heart failure, or vice versa. This is one area where I think a chest x-ray is like really, really, really helpful. A lot of these diagnoses I don't actually think you need a chest x-ray for, or a chest x-ray, you kind of get into this place of is it atelectasis versus a consolidation, and you're kind of stuck deciding what to treat. But this is one where, if you see cardiomegaly or the pulmonary edema has a pretty distinct pattern versus kind of that viral respiratory pattern, it can really help you. And really anybody that comes in with no fever, respiratory distress, and then GI symptoms, particularly in a little baby. So, poor feeding or vomiting, for example, I start to think more and more about heart failure. So I think it's an important one to consider, although not necessarily a common one that you see. You can go forward. Unfortunately, we see too many of these days. mostly due to some sort of depressing agent, so an opiate, a benzo. There's other ones that can cause respiratory depression as well. As far as age variation, it kind of depends on whether it's unintentional or intentional, and same with history. I mean, an older kid oftentimes it's a gesture and they're going to tell somebody or they let the note, or younger kids, you find the pills kind of scattered all over the floor. And again, this is really just respiratory depression. So as opposed to most of the other things I've talked about where you're going to have tachypnea or increased work of breathing, this might be this kind of very slow, shallow pattern. And of course, you should look for other toxidrome findings. Auscultation typically isn't abnormal. The one thing that you may hear is upper airway sounds, so snoring, things that suggest some sort of obstructive pattern. And again, unless it's really progressed to the point where they breathe poorly for so long that they have a lot of atelectasis, you're probably not going to have hypoxemia. So, again, it's out there in the community. It's definitely one to think about. If you have this kid that has no fever, is breathing not normally, but not fast and not working hard, sleepier than normal, and ingestion probably should be at the top of your list. And the next, I think the final slide. The last one is just metabolic acidosis. So, if your body has acidosis, it's going to compensate by trying to blow off carbon dioxide. And you will see lots of different pathology that is going to cause a metabolic acidosis. DKA is kind of the classic and obvious one that gets that kind of classic small breathing. Sepsis, especially in like a little baby that's septic, all you might get is fast breathing as a tooth complaint, and maybe fast breathing and poor feeding. And that baby could have definitely a bacterial infection. So something to think about. Kids, we see these metabolic diseases that are really rare. I hate them because they're so rare. They're hard for me to remember them all and to figure out how to work them all up. But they do exist out in the world, and unfortunately, they show up typically well after a patient's been discharged home after being born. And I think the point of metabolic acidosis is anytime you have a kid that's tachypnic or seems to be trying to increase their minute ventilation, but has a respiratory exam that's pretty clear. Now these kids could be septic due to pneumonia, so you may have findings. But if if it's inconsistent, you're kind of like, why is this kid breathing so fast? It just doesn't make any sense. I don't hear anything. They're not stridorous. They're not wheezing. Why are they breathing so fast? They're not hypoxemic. Then you should be starting to think about other things. So things that cause metabolic acidosis should certainly be on the list. I think that was my last slide. You there, Erin?
Yep, sorry, I was muted.
Okay.
Okay. Thank you, Zach. So let's first, does anybody before I just have kind of a quick case study to talk about some of the things that Zach went over, but does anybody have any questions for him? I know that was kind of a lot of information, good information, but does anybody have any questions for Zach first? Has anybody started to see any seasonal respiratory things like RSV or flu or anything yet?
I know Hendrix has seen the flu. Since I'm in education, I'm not in the ER all the time, but I know they've had some flu. I don't know if it's just been adults or children as well.
Mm-hmm.
This is Dawn Michelle. Hey, I taught ENPC earlier this week, and it had a lot of Central Indiana participants, and they said they were starting to see RSV respiratory items come in now.
Yeah. Classic time for it. Everybody excited. All right. Well, I just put together kind of a quick case study for us to go through and discuss. Again, you know, we've kind of tried to break these all of our sessions up, you know, focusing on recognition, signs and symptoms, pathophysiology, that kind of stuff. And then next month we'll get more into the meat of treatment. So I don't know if anyone has seen this, but you have a 3-month-old male who presents in the ED with a 2-day history of cough, runny nose, and now has poor PO and increased worker breathing at home. Something that we've all seen before. Yes? No?
Yes.
Yeah.
Okay.
So what are you guys going to do first when this kid comes in, whether it's through triage or you see them back in a room? What are we going to want to get first?
We undress them and start doing vitals.
Okay, great. So we definitely want to get an initial set of vitals. And with that,
My initial thought would be O2 saturation.
yeah. So I think getting a baseline set of vitals, and then while we're doing that, we're also going to want to get a full history from mom and dad or whoever their caregiver is, right?
And just look at how much that work of breathing is. Like, look at their chest and see if they're attracting what their nose is doing.
Yes. So exactly, and that's especially so 3 months old. This is something I know I would still ask mom and dad what was their birth history. You know, that's still there in that time frame where it would be helpful. You know, were they born at full term or did they come early? Because we know our premature babies are going to be at a higher risk, especially during these viral illness times. But you know, what was their birth like? Usually at 3 months old, you don't have a whole lot of other history than that. But another thing that we really need to be asking too, again, only 3 months old, but are vaccinations up to date? I don't know if you guys are seeing that more and more in the ED where they are not up to date, but definitely getting that information. I know a lot of people, you know, at Riley, we have the whole, you know, the list of all the questions we have to ask when they come in, right? Another great question, is anybody sick at home? Usually the answer is yes. Either mom or dad are sick, or there's a sibling. Or what's another place where they could be around sick contacts this age that we like to ask about?
Daycare.
Yeah, if they go to daycare. And then, so obviously, you know, we're kind of going to be doing this all at the same time because we're going to be looking at our patient, and I don't remember who said it, but we have to get them undressed, which is amazing. I think we forget to do that sometimes. And how are we going to be able to assess their retractions if we never took their little onesie off, right? So, and then I think Michelle commented on what does their breathing look like. And I think Zach, you know, really made some good points about, you know, what is our work of breathing? A lot of times I'll call and get reports from ERs and they're like, oh, their stats are this. I'm like, but they can't tell me what they look like. And then also, what's their general color? Have they had color change? You know, are they having some cyanosis? Are they pale? Are they perfusing well? All that kind of stuff that we want right in our beginning initial assessment, whether that's whoever the triage nurse is or you bring them back to. Okay. And then we're going to get more into our assessment, right? So neuro, how easy is it to get a neuro assessment on a 3-month-old? Not easy. I'll answer for you guys. Would you do a GCS on a 3-month-old? I'm just curious. I'm asking if that's something you guys would typically do. Or is it just preference? Do you guys have policies with that?
I wouldn't do, I don't know, you know, if it's a trauma patient, you think about the Glasgow Coma scale, but just how they're acting, if it's normal per mom and dad, I think that's the key thing. Well, how do the parents think the baby is right now?
Yeah, I think that's huge in your assessment, right? Because we've known this kid for how long?
Exactly, hardly at all.
Right? And they've known him his whole life. So I think definitely listening to parents, when parents, you know, a lot of times they can't articulate what it is, but they can tell you something's not right. Right? I think, you know, definitely listening to that. You know, a normal 3-month-old, you should be able to console them by, you know, swallowing them up, giving them a pacifier, you know, handing them back to mom and dad to hold and getting them out of the stranger's hands. So I think looking at things like that as well. Okay, a respiratory rate of 70 and SATs are 92% on room air. What do we think about those vitals?
It's too fast, too low.
Yeah. Okay, so definitely tachypnea. But is that all we need for our respiratory assessment?
No, you gotta see like what's retracting, their ribs, their suprasternal notch, like how bad is it?
Yeah. And I think, you know, we've got our vitals. A lot of times you'll hear the term a patient's comfortably tachypnic. Is tachypnea normal? No, but tachypnea alone, maybe not as concerning as if they have subcostal and intercostal retractions and abnormal breath sounds. So, you know, just remembering we have to do a really good, thorough respiratory assessment. I know you guys know all this, but just kind of methodically going through. So, you know, are we retracting? How, especially babies, a lot of times they'll position themselves to kind of try and open their airways. What are our breath sounds? And, you know, I think Zach made a really good point of, you know, I might listen and hear different breath sounds than Zach does, or Kamal, or, you know, Michelle or Allison. And so, you know, just making sure we're documenting really well and what are abnormal breath sounds. You know, are they bilateral or not? That's another good one, especially on some of our asthma kids like Zach was talking about. Sometimes you'll listen and you really can't hear anything. And what are we going to constantly be doing with our assessment?
Updating it and reassessing.
Yes, reassessment, right? Because we want to trend everything. So our CV assessment, our heart rate's in the 180s, blood pressure 72/44. What do we think about those vitals?
Heart rate's too fast, too high. They're pale modeled.
They're sick.
Yeah. Blood pressure is and they're 3 to 4 seconds is too long.
Yeah. And does everybody have resources that they can use for normal pediatric vital signs? Because not every age kid is going to have the same.
Right. We have a pediatric card that everybody has for the badge buddy that they carry on their badge for normal, so they can just do a real quick look
That's
at.
great. Yeah. And I would just recommend that everybody either, especially if you're not used to peds, you know, have some sort of resource you can use, whether it's posted in the room or you have a badge buddy, or, you know, you can pull it up on the computer, whatever is easiest. Because, you know, how do we know, you know, it's really going to dictate our assessment, knowing what our normal vitals should be, right? And then our abdomen soft, non-tender with hypoactive bowel sounds. So I think someone already said it, but is this kid sick or not sick?
Sick.
That was a resounding sick. So, you know, we really wanted to kind of just focus on assessment today. I know that kind of, you know, really only leaves you with half a case study, because the next part of it would be, what are we going to do about it? So I think, you know, we're really going to get into that next month, as far as not just treating some of the specific etiologies that Zach was talking about, but in general, what's respiratory support that we can provide? You know, what do you guys have available to you in the EDs? And is everybody comfortable with that? So we're really going to get into that next month. Do you guys have any questions or comments, or anything about today? And if you guys think of stuff, if you have questions after the fact or don't want to chat in front of everyone, please feel free to just shoot me an email, and I will certainly answers and put you in touch with the right people.
Thank you. Always very informative.
Good, good. I know we're just about out of time, but just real quick, in planning for next month, I'm curious, does everybody at their facilities have access or utilize some sort of high flow nasal cannula, whether it's OptiFlow or Vapotherm or whatever brand name? Or is that something
We do,
different?
yes.
Okay.
Yes.
It does.
Yep.
Ball does, yes.
Okay. And is that something that would be helpful to kind of spend some time talking about that, or what?
I think when you go over the treatment of different things, what's recommended for each, disease process, I think that could be helpful. I've been a nurse for a while, but not with peds and not with respiratory stuff. So I think that would be helpful.
Okay.
Yeah, I agree. And we also have a lot of RT, that does that. So I think from our side, it would be helpful because we know about it and we can do it, but they do it a lot more also. So a little extra information would be helpful.
Okay. Okay. I just want to check. We've gotten a lot of requests about that in the past. So I was just kind of curious to pick your guys' brain since I had you here with me. So thank you all for joining. We really appreciate you taking some time and chatting and listening with us. Again, if you have any questions, whether it's regarding the session, pediatrics in general, any questions, please shoot me an email. I say this every time, but no one ever is. But if you are interested in presenting a case for the next session, please reach out to me. I'd be happy to help you or tag team it. I'm not going to throw you to the wolves and put you on the spot. And then I'm going to edit the calendar invite because we are going to bump next sessions up. It'll actually be on the second Thursday of the month instead of the third. So it'll be November 14th at noon because Brenda, we may be seeing you. We will be at IU Ball for Sim Day on the 21st. So.
Oh, yay. Okay.
We're just going to bump it up a day. And I'll fix the calendar invite so it reflects that, but just give you guys a heads up. Okay. Well, thank you guys for participating. And, let us know if you need anything in the meantime, and hopefully we'll talk to you next month.
Thank you.
Thank you so much.
Thank you, ma'am.
Have a good day.
Thank you.
Thanks.